Hi, everyone. Good morning. Sorry for the inconvenience. Thank you all for joining us. My name is Anna Rossetti, and I am the Director of State Health Policy and Advocacy at Vitalyst Health Foundation. We are here today to talk about the Arizona's 2025 legislative session, and we have our special guest, Will Humble, who is the Executive Director of the Arizona Public Health Association. Of course, Will has been doing this work for many years, and so he will obviously cover all of the bills that were, either passed or vetoed during the last session. So again, thank you all for being here, and I apologize again for the inconvenience. And so, Will, I will advance your slide. Take it away. Thank you.
Well, thanks, Anna, and thanks for the invitation, Vitalyst, to do this presentation. And thank you, for the attendees, for coming here on a Tuesday noon to learn more about the legislative session. Before I get started, Anna, do you want to push record on this so that we have this and we can load it to the website later?
Hold on a sec.
In case people want
I
to.
think it's already recording.
Okay, I just didn't push the thing that I say accept record. So, but I get maybe it is. Okay.
Yeah, it's already recording, Will.
Okay, good. Thanks for attending, everybody. So it was, as many of you know, a really typically long legislative session. They always have a goal of finishing within 100 days. They never meet that goal, or hardly ever. Maybe once in my whole career have they done that. But it was definitely a busy session. And so what we're going to do today is cover the legislative session from a public health perspective. So we're going to look at the bills, that the policy type bills that made it through the various committees and that the governor signed. We're also going to briefly cover those bills that would have been harmful to public health policy that the governor thankfully vetoed. And then we will get into the nitty-gritty of the detail of the budget that was negotiated and in the end signed by the governor. So Anna, you're going to advance the slides. I think we have until about 1:30 on this, but I got a ton of slides, so I'm going to have to move pretty quickly. And as we go through the slides, go ahead and advance. I want to let you know that you can go to my blog and get this presentation. And when you go ahead and advance one more, and the bills that you see here, like this, for example, you could click on where it says SB 1308. You could click on that and it will take you right to the actual bill, and you can take a look at that. So let's go ahead and start with the good stuff. That's why you see the little green check mark here. What that means is that this was a bill that we at AZPHA supported and think is good public health policy. All these are bills that made it through the legislative session and that the governor signed. So this first one is among bills in the last 2 or 3 years that have been taken up by the legislature to help improve the performance of the licensing system for both residential settings like behavioral health group homes, in this case, like sober living homes, but also assisted living and skilled nursing facilities. So this one, 1308, addresses some shortcomings that we have all observed over the last few years with the regulation of sober living homes. This requires the state health department to establish new regulations for sober living facilities to make sure that licensed facilities actually provide life skills development programs, independent living skill programs, that they really do forbid alcohol and drugs inside the facilities, and also provides the state health department with some additional regulatory authority so that they can assess more civil money penalties when they identify sober living homes that are doing a bad job. Now, at first, it might not seem like raising the civil money penalties from $500 per deficiency to $1,000 per day is a big deal. But in reality, you see the bottom bullet here, penalties can be assessed per person per day. So that means that if you've got, let's say, 8 people in a sober living home and there's a significant deficiency, they're not following the regulations, instead of just the old $500 fine, which is pocket change and basically the cost of doing business, the department has the authority to assess up to $1,000 per person per day. So that could potentially be $8,000 per day if there was 8 people in the facility. Not saying they're going to do that, but it gives them a much bigger hammer to compel compliance with sober living facilities that are not performing the way I think we all expect them to do. Okay, next slide. Next one is also a licensing slide. This is across the entire spectrum of licensed facilities that ADHS State Health Department handles. It requires the agency, to put a priority matrix together for complaints filed against healthcare institutions. Maybe some of you remember a few years back, the Auditor General put out a report that demonstrated the State Health Department was not following up on complaint investigations at assisted living and mostly skilled nursing facilities. That they're making big strides in improving that performance, but this provides some more clarity about how they make decisions. Not all complaints are created equal. Say, for example, medication errors is a really bad deficiency compared to some of the other kinds of things that you might find in a skilled nursing facility, and those things need to be addressed more quickly. So there's that, and then there's an additional annual training program that the State Health Department will be putting together. When this is all going to take effect after these bills are implemented, which should be in about September this year. Then they're going to have to go through the process of improving the performance and using the additional authority and doing some additional rules. Okay, so next slide. Anna, can you advance this? Okay. This has to do with health insurance. There were actually a few bills this year that were consumer protection bills to ensure that people who have health insurance are treated fairly and transparently. This is a bill that's going to require health plans to individually review denials of claims and prior authorizations. There's been a trend nationally and to some extent in Arizona where health plans have been using AI to decide and do the screening for what they're going to, claims they might deny or prior authorizations. And a lot of that has to do how well a job that does, of course, depends on how the AI is trained. What this bill does is require a actual person to make the final decision. So it doesn't say that health plans can't use AI as part of their process, but it prevents them from using AI or surrogates solely as the way of denying claims and prior authorizations. So that's Senate Bill 2175. And you'll see in the missed opportunities part of my presentation, there was another bill that would have really been good for transparency at health plans. That didn't pass. Let's go on to the next one.
Will, sorry, there's a delay. Hold on.
Oh, okay.
Okay.
Why don't you click it again? Because
Yeah. There you
okay. This is about credentialing. So if you this came up in our recent board meeting at Vitalyst a while back, or maybe at our last meeting, about credentialing of providers. One of the issues we have a lot of workforce problems, obviously, in Arizona, in the healthcare workforce, physician workforce, et cetera. One of the bottlenecks that we've been seeing on a temporary basis, or that's not going to solve the problem, but it's making things worse, is that when let's say a hospital system or health or provider network is hiring doctors, nurse practitioners, et cetera, to perform in the network, they've had a really hard time getting that provider credentialed. So then maybe they're recruiting them from Albuquerque or something like that, and they get here and then they can't get credentialed with the health plans. And so, which means puts them on the sideline and then means that they're not billable, which really harms our ability to recruit physicians and healthcare providers from other states. So this bill, when it goes into effect in a couple of months, SB 1291 requires health insurers to finish provider credentialing within 60, and it's working days. I didn't put working in there, but it's 60 working days. And this will, it won't solve our workforce problem, but it will help improve our ability to recruit from other states and to get people actually performing in clinical settings more quickly. So that's 1291. So Anna, let's go ahead and advance. Okay. This is one I've been personally working on for 4 years with a lot of other people. And finally got it over the line. A few years ago, we were able to establish a category of licensed facility called secure residential behavioral health facilities. Those facilities exist on paper through statute, but they don't exist in real life because the provider network at Access has never invested in that, and Access has never, to my knowledge, compelled or even honestly encouraged these secure behavioral health residential facilities. When in talking to stakeholders, what we have discovered is that when we got this bill passed a few years ago to create secure residential behavioral health facilities, it on paper would theoretically allow patients who are not competent to stand trial, so criminal justice patients, could get mixed in theoretically with people under court ordered treatment for just civil commitment for like some SMI disorder. And we've heard that that could be a barrier as to why these facilities haven't been established. And so this was a cleanup bill that we got through 1604, which then says now people who need treatment at not yet existing behavioral health residential facilities, you can't mix the two populations. The criminal and the civil patients can't be in the same building. And so we're hoping that that removes that administrative barrier. The reason these facilities are important is because we have some capacity for inpatient hospitalization. So for people on a civil commitment, for example, for a psychiatric disorder, that's a secure setting in a hospital type setting. But the only other setting that we have is a behavioral health group home, which is not secure at all. And if a patient is getting court ordered treatment in that facility and needs a more secure environment, that type of facility doesn't exist yet. And what that means is people end up in residential behavioral health group homes on court ordered treatment, but they don't want to follow their treatment or stop following their treatment. And then they decide they don't want to be there anymore and they walk away. And the parent who went through so much work to get the court ordered treatment for their loved one is frustrated because and scared because their son or daughter left and they can't find him because it wasn't a secure facility. Now, this isn't a type of facility that's needed in, it's just a very small subset of court ordered treatment cases, but it's a real gap in our system of care for people with a serious mental illness. This is one of the barriers that we think may have been holding up the development of secure residential facilities. And when we get to the budget part, I'll follow up on this one a little bit more. Okay, next slide. Okay, this is something that rural county health departments have been working on for quite some time. There's certain functions within county health departments that can only be done by what's called a registered sanitarian. So these are people who go out into the field and do inspections of restaurants. They might do perk tests for septic tanks. They on public pools or semi-public pools like apartment complexes. They do those inspections. It's actually how I started off in public health back in the 1980s. And so it's been really hard for the rural county health departments to recruit people that are registered as sanitarians that can do this work. And so this is a bill the counties have been working on that we helped a little bit on. House Bill 2145, which says you can take the test to become a registered sanitarian if you have 3 years of experience as a sanitarian aide, or if you were in the military, as opposed to 5 years. So that's, we hope that this builds the inventory of people who can take the test and then be able to do that critical work, that environmental health work out, especially in the rural county health departments. I'm not saying Maricopa and Pima County don't have trouble recruiting sanitarians, but it's a lot harder in some of these other rural counties. And from what I understand, this was a bill that was really worked on, I think, by Mojave County. So hopefully this helps the public health workforce a little bit. All right, next slide. Most of you probably have heard this because Mr. Kennedy showed up in Arizona to tout this bill, which the governor signed, House Bill 2164. It basically says that schools that participate in free and reduced lunch programs, mostly Title I, but not all, can no longer have third parties selling ultra processed foods on campus. So think about, let's say, the fundraisers for the Palm and Cheer Squad. Let me just make that up out of thin air. Maybe they would sell chocolate bars as a way of raising money. Well, they would have to switch to maybe selling apples or something like that. I would just, you can see on my third bullet here, I wonder where the line stops, because ultra processed food isn't super well defined. This all is going to start in 2026, 2027 school year. So the upcoming school year, this won't exist yet, but there'll be some limitations on what you can sell or serve in schools that participate in free and reduced lunch. So the cafeteria people are going to have to do some research and figure out what it is that they can buy and afford and put on plates for kids that are not considered ultra processed. And I don't know who the regulatory authority here is. Is it the Arizona Department of Education? I'm not quite sure. Okay, next slide. Okay, this is a cleanup bill. Many of you will remember the Arizona Opioid Epidemic Act from a few years ago, probably think 2018, maybe something like that. And one of the things that was much of that was good public health policy work. But one of the things that we discovered over the last few years is that the requirement that opioids have a red cap on top of the pill bottle was, it was a good idea in that you thought, okay, people will know what an opioid is because it'll have a red top. They'll know that they need to be careful with it, etc. But what ended up happening is it made it a lot easier for teens and others to divert those opioids, because they could go into somebody like their friend's parents' medicine cabinet or something, and instead of spending a bunch of time looking at each pill, they just look for the ones with a red cap and then steal the pills out of the container. So in the end, we discovered that red cap provision was doing more harm than good, making it easier to divert. And so this is just a cleanup bill that says, okay, opioid containers that coming out of pharmacies, they don't need to have a red cap anymore. So you should start seeing those red caps start to disappear, at least from the pharmacies, but they're still going to be in lots of medicine cabinets all around the state for probably a long time. Okay, next slide. This is a group of folks worked pretty hard on this bill, 2179, which establishes some more restrictions on advertising of marijuana products and paraphernalia, mostly products. And any one of you that drive around town have seen the ads on the billboards. It looks like when it's not a political season, pretty much all the ads, it seems like to me, or have to do with weed. And so this puts some additional limits on what billboards dispensaries can buy, how close they can be to schools, the types of characters that they can use. And it also says that dispensaries have some limitations on what kinds of things they can sponsor, especially if it has to do with young adult events. So there's some more restrictions on the retail marijuana industry. Okay, this is 1727. So it kind of goes along with the other bill I talked about a few minutes ago about credentialing. This is going to at least require the U of A, which is the all in-state medical schools eventually, but U of A is the only one right now. That's a public institution, medical school. U of A and NAU are in the process of making medical schools, but in order to do a better job at retaining graduates in state after they've gone to school in state. This will require in-state medical schools to at least interview every qualified applicant from Arizona and give them priority consideration in the first round when they're offering slots in their medical school. So in theory, this will keep more Arizonans in medical school in Arizona. Perhaps some of them will put down more roots. And then we still need to do a better job with residency programs in state. But the idea is the more time people spend in Arizona, the more likely they are to end up practicing here. And this at least gives candidates that are in state an opportunity to at least be considered for admission to Arizona public medical schools. So it doesn't apply to like Creighton and stuff like that. But it does to U of A now, and it will apply to NAU and ASU when they get their medical schools up and running. Okay, next. This is Annalise Ortiz worked hard on this bill. She got it through, trying to do something about the issues around heat-related illness for occupational exposure here. What the 1182 says is that in the summertime, during the hot periods of the year from May to October, construction work can begin at 5 o'clock in the morning and 7 o'clock on Saturdays. So local jurisdictions, so it's a preemption bill. Some local jurisdictions have say you can't start work until like 8 o'clock or 7 o'clock, and obviously, at least in the deserts here, you got to get going at 5 if you're going to knock off at 1. When it gets really really hot. So pretty soon they'll be able to start work at 5 a.m. even if the city doesn't allow it. What I looked in this bill specifically for HOAs, because many of you know how unreasonable they can be. I couldn't see anything that preempted HOAs on this. So I don't know what the actual impact is going to be in some of these HOA neighborhoods. But anyway, it's a good start. And, maybe this will need a cleanup bill to stop HOAs from misbehaving on this. But at least it's a good program for those working outside in the summer doing construction work. It didn't apply to yard work like chainsaws and stuff like that. It just applied to housework. Okay, next. This happened at the very end of the session that went through Senate Bill 1247. It moves the tobacco legal buy age in Arizona from 18 to 21. The feds have already moved it to 21, but the compliance with that is spotty in retail stores. This moves the legal age to 21 for the purposes of in-state law. In terms of enforcement, it's pretty lame because it's just called a petty offense to sell to a minor, which is the same fine, for example, for spitting on the sidewalk. That's called a petty offense. Same thing. I think it's a $50 fine at the most. So enforcement isn't going to be super robust, but at least it does move it up to 21. And that, by the way, includes vapes, not just lit tobacco products. One of the pieces of drama with this bill ended up being, people who said, look, you could sign up for the Marines at 18, but then you can't buy cigarettes. That doesn't make sense. So they exempted active duty soldiers and National Guard from the provision, so they can still buy vapes or cigarettes or cigars and stuff. And my attitude is, look, let's take the win. And there were others like the purists in public health were like, oh no, we don't want to exempt the soldiers. Um, I'm like, look, just as a practical matter, this is better than nothing. So I think it's a good public health move. Okay, next. Okay, now let's move into the budget reconciliation bill. So just as a primer on that, so most of the bills we've been talking about so far, those are bills that, there's a sponsor in the House, maybe a sponsor in the Senate too. Sometimes there's one bill, sometimes there are two, and they accomplish sort of a similar goal, and the governor needs to sign it in the end. There's another kinds of bills that are associated with a budget called budget reconciliation bills, and you'll hear them as called BRBs, BRBs. And what these are designed to do is to implement things that are contemplated in the budget. So it provides some statutory authority for agencies to behave in certain ways in order to implement what's intended through the budget bills. So we were finally able to get access permission to actually implement their traditional healing services waiver, which has already been approved by Center for Medicare and Medicaid Services, but access needed authority to implement that law. This budget reconciliation bill does that. We're, I think, one of the first states. I see Kim is on here too, and we'll get to a Q&A at the end. I know, Kim, you worked hard on this, Russell. But I think we're one of the first states to build this into our Medicaid program. There may be 4 others or so. But this is encouraging because there's a lot of things, both on the behavioral health and acute care side, where people, tribal members can really benefit from traditional healing. And this will build a network of people who can actually do that work and get reimbursed for their services. There was also attached to this budget reconciliation bill $100,000 in implementing funds. So that it doesn't sound like a lot of money, and they don't need a lot of money for this at Access because the treaties and so forth that were signed with the Native American tribes, and that part of that included healthcare, and so the feds cover almost 100% of healthcare services for tribal members. So this will be the vast majority of this will be federal funds that'll be providing these traditional healing services with no match. But Access needed about $100,000 to implement. So they actually got that money in the budget. So they got the authority, which is the most important thing, and then the $100,000 to implement the program. So that should begin later on this year. So big win for tribal country. All of us, really. So here's a 1741 is also a bill that was in that final budget reconciliation bill 1741. This allows Access to implement, well, much like the tribal thing. Access had authority. They had their waiver from CMS done. They just didn't have the authorization to proceed on that tribal healing services. Same thing goes with this budget reconciliation bill initiative around supporting pre-release medical service transition for people that are in, say, for Department of Corrections, or I guess it could be in the county jail too, where before release, you can enroll them in Access and then start providing transitional medical services. So you can imagine opioid use disorder treatment or other, whatever it is. And so by the time that person is released from the correction system, they've had some transition care. They have a provider, hopefully, that they can then continue to see. But it builds sort of a linkage between release from the correction system and then getting your healthcare by having that overlap for 90 days. And so it was encouraging to see this go through. Again, that was not a regular bill. It was just built into the budget reconciliation bill. Okay, next slide. Same thing here. This was a, I think, SHOP bill originally to try to get access to cover speech therapy and cochlear implants among people over 21 years old. Those bills failed to progress through the system, but they didn't give up, or I'm assuming this was SHOP that didn't give up. They got it built into the budget reconciliation bill. So people under 21, when it's medically necessary, access can pay for cochlear implants and speech therapy. But once you hit 21, then that was no longer a benefit that people could get. So after this becomes implemented later on in the year, people over 21, when medically necessary, should be able to get cochlear implants for this benefit. Interestingly, when I read the details of the bill, I could see that it does not apply to the expansion population. So it would not apply to childless adults and Medicaid members who are between 100 and 138% of the federal poverty level. But a lot more people will then qualify for these cochlear implants moving forward. One of my pet peeves at Access is that it's nice that this is covered now as a benefit, but bone anchored hearing aids are not, which is they're way less expensive than a cochlear implant and are something that's needed for people with middle ear problems. But sadly, they still cannot get bone anchored hearing aid. But at least once this takes effect, cochlear implants are going to become at least possible for some Medicaid members that are over 21. This is interesting. That was built into the budget reconciliation bill, Burb, and I don't know what the motivation is for it. I'm not a big fan of this, so I'm not saying this is a good bill. I can't tell you that it's terrible, but Access is required to offer extensions to all of their managed care contracts and rebas through September 30th of 2028. So what would have been a normal RFP season coming up this next year, the can's going to be kicked down the road for about 18 months. So we're not going to see RFPs out of Access, most likely for a few years. So I don't know what's behind that, but it's probably managed care organizations. Maybe you're working at one of those and maybe your leadership is happy about this because they can keep their contracts. But some people who might want to get into the business of Medicaid in Arizona will not be able to compete for those contracts because for the next few years. Anyway, I don't know what's behind that, but so I didn't put a little green check in it because I'm not convinced that this is a good thing. But anyway, it passed and it was in the final budget that the governor signed. Okay. There's only one signed bad bill, in my opinion, bad. Maybe some of you don't think it is. The governor signed this bill, House Bill 2679. What this allows is for utilities. I almost said public utilities. No, monopoly utilities like APS, Tucson Electric Power. They can issue bonds for some of their high interest debt that they have, and in particular debt from old coal plants, which we still have 3, I think, in operation in Arizona. And it allows them to bond it and then force the ratepayers to pay it off. So eventually, if you're in the APS service area, you're going to end up seeing a non-bypassable fee that you cannot avoid that will be going towards paying off a bond so that APS can keep coal still going, and they get their shareholders at APS and TEP, they get relief. The people own stock in Pinnacle West, they're happy as a clam because they package all these high interest rate bonds into these bonds that then the ratepayers have. So in my opinion, the people who own the stock in Pinnacle West should be paying for the mistakes that their CEOs make and the debt that incurs that they have to pay off. And I don't think they should punish ratepayers for that who can't, it's not like you can go shopping for electricity with someone else. You're stuck. So this, I'm kind of ticked that Hobbs signed this, and maybe she's mad at me for what I said in the paper about her signing it, but I don't know. I think it's bad policy, and I'll be able to afford it. So it's like it's not gonna punish me. But there's a lot of people that are paycheck to paycheck, and affordable housing is already a problem, and inflation's caused a lot of stuff like food to get more expensive. And now this is just going to make electricity even that much more expensive with these non-bypassable fees. So I was disappointed to see this happen. All right, next slide. Okay, Governor vetoed a lot of bad stuff. So let's dive into some of those. I won't spend a ton of time on these because I want to get to the budget part of it. This was a bill that she vetoed that would have required schools to advertise to parents that they don't have to vaccinate their kids. In other words, schools would have to say, "Oh, by the way, you can sign this personal exemption and not vaccinate your kids." They could. There is such thing as a personal exemption, but it would have just made things that much worse to basically advertise to parents that we really don't have an enforceable vaccine requirement for school attendance in our state. Okay, so she vetoed that. That's good. Next. This is another vaccine bill that she vetoed. Would have prevented DCS from refusing to place a kid in a foster home based on the vaccination status of the kids. So the idea is, let's say you have a kid who is medically fragile and unable to be vaccinated because of a medical condition, and they're in the foster care system, and DCS might have an unvaccinated potential home, I mean, full of unvaccinated people, but they might want to like, oh, geez, we can't risk putting this kid in this unvaccinated home because this is a medically fragile kid. This would have prevented DCS from making that kind of decision. Thankfully, she vetoed it. Not saying that this was tons of this isn't like tons of foster kids that this is happening with, but it was, I think, a potentially harmful policy at a micro level. So I was pleased to see that she vetoed this bill. Next. This is one that she vetoed that would have allowed, would have said parents can get their kids' medical record, access to their kids' medical record, regardless of whether parental consent is required for the treatment. Where this bill, had she signed it, would have been a real problem is with sexually transmitted infections. So you can imagine there's teenagers out there that are sexually active and their parents don't know they are, and then they end up with gonorrhea or chlamydia or something like that. And you could imagine that if they knew, and by the way, though, there's no parental consent needed for treatment for those infections. And you can imagine kids thinking, I'm just going to suffer with this disease or get antibiotics from Mexico or whatever. I don't know. Because I know my mom's going to look at my medical records and I'll get in huge trouble. I said mom, but could be dad too. But so in terms of STIs, I think this would have been harmful. You could read it on the surface and think of it as like cancer and things like that. No, that's not what this is about. This was really, I think, the main harm would have come with the spread of STIs among adolescents. Okay, next. This was a long bill, and I only have one bullet here. So there's no way I can capture what this would have done. But it added a whole bunch of red tape to what DEA, Department of Economic Security, would need to do. They're the ones, that's the agency that coordinates the Supplemental Nutrition Assistance Program benefits, or SNAP, otherwise known as food stamps. It would have really made DES's administrative job a lot harder without, I couldn't see any real benefit. It would just have made DES do things a lot more slowly, so people wouldn't be enrolled as quickly as they otherwise would have. So I was thankful to see her veto this bill. Okay, next one. You probably read about this one in the paper that she vetoed. This would have required not hospitals to ask patients whether they're lawfully present in the US. And now if they didn't answer the question, they would still have to provide treatment under EMTALA and so forth. But it would have been required to be reported to the state health department. And you can imagine, especially what's going on with these ICE raids around the country and how it's going to get a lot worse. I mean, the ICE budget's going to triple or quadruple now. And so they're going to have a lot more of these agents that you see wearing masks out in the field. And that's going to be happening for a long time. You can imagine the chilling effect that would have occurred had this bill gone through with respect to people just deciding not to seek hospital care. And it's probably happening already, where people are afraid to even get medical care because they're afraid, someone is going to tip them off from the hospital and there'll be an ICE agent waiting in the parking lot. So, I mean, it's really bad. And, there's nothing I can do to stop all that stuff. But this would have really made, I think, things even worse had she signed the bill. So I was pleased to see her veto that. Next, injury prevention. This is a perennial bill. I think it's passed. Even Ducey, I think, used to veto this. Would have allowed, although I don't know if he did. Brewer did veto it a couple times. Would have allowed people to carry pistols, hidden pistols, onto campus at universities, not high schools, but with universities. So thankfully, governor vetoed this. This was vetoed at the very end. This is probably, I think, the last bill that she may have vetoed. It would have forbidden the use of photo enforcement, both speeding and running red lights in Arizona. The red light cameras, by the way, are a really effective public health intervention. They really if they're put in the right intersection, they dramatically reduce those violent T-bone crashes that kill people. There's a lot less evidence that photo radar saves lives. So photo enforcement is I mean, there's the red light cameras, which we know work. The photo speeding cameras may or may not work. I think make sense in school zones. Anyway, the bill passed, but Governor Hobbs vetoed it. I wouldn't be surprised to see a photo enforcement initiative or a referendum be on the ballot next year in 2026. There are certain jurisdictions, Paradise Valley being one of them, that really overuse photo enforcement, and they may end up jeopardizing it for all of the cities. Phoenix has plans to put in, I think, 12 or so in the next 6 months. Let me talk about missed opportunities for a minute. This is a bill the governor vetoed that I think is a good bill. Senate Bill 1612. It would have required, mostly it's good for transparency. It's not a core basic public health bill, but with respect to government transparency, I think it was a really good bill. It would have, first of all, made all of the state agencies that do state procurements, they would have to be more diligent about the documents that they keep, the notes that they take, the transparency during the RFP process, the accountability, and making it more fair to all the bidders who want to bid on work that the state needs, everything from roads like ADOT does to these massive contracts that Access puts out. So it would have really put some good guardrails on transparency and fairness across the entire state government enterprise. So I was really disappointed to see Governor Hobbs veto this one. It would have also, which I think is needed, made Access follow the state procurement code for these multi-billion-dollar managed care contracts. So if you look at the way Arizona spends taxpayer money, by far the biggest government contracts there are, and bigger than widening I-17, for example, are these contracts that Access has for acute care and behavioral health care. And ever since Access became a state agency back in 1982, they've been exempt from following the state procurement code for those massive contracts. And I've always thought that that's wrong, because under a competitive system, you're more likely to have a good outcome and good vendors. Doesn't guarantee that the agency is going to do good, contract management on behalf of the people, but you're more likely to get good results with a transparent process. And governor vetoed this, but I really believe Access should be made to follow the state procurement code, just like all the other state agencies do. Now the universities are exempt just like Access, but it's just a missed opportunity, in my opinion, to improve the performance of state government. I don't see it as partisan, and I honestly, I don't know why she vetoed it. Anyway, doesn't matter. She did. All right, next. I like this bill, and it's not public health necessarily, but I think it fosters more back and forth and checks and balances. This was a legislator's bill that I'm not fond with, a guy named Colladine, but it would have required the governor to appear before the legislature to answer questions every month during the legislative session. So it would have required the governor to come, for example, to a joint session of the House and Senate for a Q&A period once a month, much like you see, like if you ever watch over in the UK, how Parliament works. They got the Prime Minister, and he brings that, or she brings that book up, and they all yell at him and for her. Anyway, I think it's important to have the governor and for that matter, the governor's agency directors held accountable, and to be able to, force them to answer questions from the legislature. So this is something that got vetoed. It just never made it through the legislative session, but I thought it's kind of fun. I think it's a good idea, so I put it in the slide deck. Okay, I think the budget is next. No. So here are the things, the bills that never got traction that would, I think, have been mostly good for public health. This is a many years project to try to get some comprehensive oral health coverage for Medicaid members. This would allow Medicaid members to use their $1,000 Medicaid annual benefit for more than just extractions and root canals and stuff, but they could actually go in and do x-rays and get some cleanings, to prevent cavities and stuff, instead of just pulling teeth out at the end. Sadly, that failed again this year. There was a bill that I shouldn't say who killed it, but probably the managed care organizations killed it, to add a whole bunch of consumer protections for denied health insurance claims and prior auths, so that when you need a procedure, or you think you need a procedure and your doctor thinks you need a procedure, but your health plan denies it, or either the prior auth or the claim at the end, it would have made it real explicit as to how you could proceed and who you should contact at the health plan and what you should do and how to do it. And it would have made the health plans more accountable for denying those claims. So it made it through the first house, whether it was the House or Senate, I forgot. And then it's just stopped dead in its tracks, which is usually a sign that the industry found a way to get somebody to kill it. Again, I'm reading between the lines on that. There was a bunch of bills that got passed, never even got hearings, around evidence-based firearm protection. So things like child access prevention laws, things like that. So that those were bills that never even got a hearing, missed opportunities. I won't spend a lot of time on interfacility ambulance service, but there's a lot of patients getting stuck at one hospital and they need surgery at another hospital, and the ambulance service is really bad, and it takes hours, in some cases a day, to move the patient. And there was a fixed bill that would have helped provide better interfacility transport service. Sadly, that failed. Retail licensing of tobacco facilities, that was a bill that never got a hearing. I was in favor of a bill that would have allowed psychiatrists or psychologists with certain kinds of clinical training to prescribe certain kinds of medications. As you know, we have a huge shortage of psychiatrists. And this would have, I think, helped, maybe in rural areas especially. Sadly, this was a food fight between the psychologists and the psychiatrists, and the psychiatrist won this year. A bunch of folks, Mad Moms, and others, Acme, chronically mentally ill group, worked really hard to try to get eligibility in out state's long-term care system for patients with a serious mental illness like schizophrenia, to get into the Altex system. So people with developmental disabilities have a relatively easy pathway into Altex, but people with a serious mental illness often have a big struggle. This was, I think, an important bill that was really health equity, honestly. Sadly, that did not make it through the process. And I think a real nice prevention bill that would be good was a bill that never made it again. This has been proposed like 3 years in a row now. And what would have allowed families to do is to have electronic cameras and monitoring in assisted living and skilled nursing facilities. So, for example, my parents live in an independent living place. And if, let's say they were in assisted living, I might be able to put a camera if they agreed to it so that I could see what's going on. Obviously, the industry does not like that and fought tooth and nail to avoid that, because I probably should not ad lib as to why, but they hated the bill and were able to kill it again. It would not have forced cameras into rooms. What it would have said is, if everyone agrees, including the residents, then you could do it as long as you pay for it yourself and everything. And even if there's another roommate, that they would have to agree to the camera as well. Anyway, prevention is always better than writing up a deficiency and asking for correction. This is a great prevention bill. Sadly, the industry made sure it didn't happen and didn't get enough traction. Okay, next, I think we're towards the budget part, and then we can open for Q&A. Okay, so I'll just run through. This is all new money, so all I'm putting up here is not the ongoing funding, but anything that's just new. So the governor was really firm on insisting on some additional $45 million for childcare assistance for low-income families, $5 million for ibogaine clinical research trials. I'm not sure what ibogaine is. Senator Sinema was the one pushing, former Senator Sinema pushed for this down at the Capitol. We did get $5 million in capital to begin building secure residential behavioral health facilities. So hopefully that gets the pump primed a bit so that we can get these badly needed facilities up and running. I talked about a half hour ago about the real need for this sort of intermediate type of facility for people getting court order treatment for a serious mental illness, not for the long term, but just to be in a more secure setting until like their medications kick in and they get into a more stable situation. We got $4 million in new money for graduate medical education, so that's good for building the healthcare workforce, especially as doctors and other healthcare providers begin retiring. And someone was able to squeeze in $2 million for the produce incentive program. So I'm not sure who that was, but it's a good thing. All right, next. $1.5 million for nursing education at community colleges. 750,000 for dementia awareness campaign at the state health department. Not sure what's going to be part of that, but they'll be doing some, I guess, PSAs. I'm not sure what they're going to do with that money. $500,000 for AEDs at public high school athletics. So AEDs are like if you have cardiac arrest, there are those things that you see. Maybe you've seen them in the gym or at the wherever you go in public. A lot of times there's AEDs with a little lightning bolt on it, and those are things. If someone has a witness cardiac arrest, you pull them off the wall, put it on their chest, There's a 1, 2, 3 steps to, and it shocks them to their heart starts back up. So I don't know how the 500,000 is going to be distributed or which schools are going to get it, but so that's a new appropriation. And then there's a bunch of stuff for the state mental hospital. Apparently, they're way behind on spending too much money because they needed $3 million of supplemental funding for shortfall on operations there. They also got some money for anti-ligature. Those are ligature means places where someone could decide to hang themselves, like a hook or something like that. So maybe it's new door. I don't know what the deal is, but they needed $700,000 to prevent people from harming themselves at the state hospital. Perimeter detection system, that's probably around ACPTC is my guess. And I don't know what isolation valves are. I should know that, but I don't know that. Okay. I think that may be it, Anna. Let's see. Oh, I already mentioned that Access gets a free, they don't have to do RFPs for a while. And I already mentioned that Access can now pursue traditional healing. They have that authority and they got a little appropriation to get it going. Okay. I think we're down to Q&A. All right. So Anna, you can stop sharing the screen now if you want, and we can open it up for questions for the next 15 or 20 minutes. I'm not running this, so
Will, can you hear me?
yeah, so you can have people raise their hand and then you call on them, right? Is
Okay,
that how
well,
this will work?
actually, I can just read the questions.
Oh, from the chat? Okay.
Can you hear me? Okay, so the first question is from Rachel. Advocates are hearing that the 5 million for SBHRF took $2 million away from the current SMI housing fund. I don't know if
Oh,
that's a question or.
yeah, so I did not get into the details of what fund the 5 million came out of. So I can't confirm that that's the case, but it might be true. I mean, you have to go deep into that. It's a couple 100-page bill. You have to really get into the nitty-gritty detail to see which fund what came out of. And so in that big feed bill, that's where you can find the answer to that question by looking at the main feed bill. And going down to the access line and seeing where it came from, and they use it from, like, you'll see that they use some stuff is like the drug rebate program, and there's different funds within access and I don't know where they got that. It could be true, it might not be. Okay, next.
Okay, so the next question is from Lisa Castellanos, and she's from the Arizona Mad Mom from Scottsdale. She has two questions. The first one is about House Bill 2926 dash 571R, access eligibility. What happened to this bill this year, and will it be reintroduced in 2026 as part of the legislative process to implement HR1? And then the second question, do you want me to read the second question now or later?
No, you better not, because I don't have that much synapse power. Yeah, I believe I didn't memorize the bill number, but I believe you're referring to what I referred to as a missed opportunity, but really health equity, I think, is to allow, as I mentioned, people with developmental disabilities. It's not automatic that they get into Altex, but they have like a person with Down syndrome, for example, it's pretty close to automatic that they could get into the Altex system, and which provides a more robust set of services. And there are many people with a serious mental illness, schizoaffective disorder, schizophrenia, sometimes bipolar, things like that, where honestly, their disability is more profound than many of the people with developmental disabilities that in the Altex program. But there has always been in state law this unfair distinction between developmental disabilities and psychiatric disabilities. And so this, sadly, the bill I'm thinking of is the bill that I wish had made it through, I don't have any inside information on why it failed to make it over the line in the end. I know that there were some lawmakers that felt, the Hernandez, especially lawmakers that felt strongly about it and tried. I don't, into the second part of that question, will it be introduced? I'm certain that with Matt Moms out there in the field, that you will make sure that it gets reintroduced next year. You're a remarkable stakeholder group that I think, you know, um, academic classes should use you guys as a case study in how to organize. Anyway,
Hey,
second
Will.
part of that question.
Oh, okay. So, but just to clarify, the HB 2926 is related to the FMAP, and that is the threshold from 90% to 80%.
Oh,
And
okay.
so her question is whether or not that will be reintroduced in 2026 as part of the legislative process.
It probably won't be necessary because the House version of that bill of the HR1, the initial House version had a reduction in the FMAP, which would have really left the childless adults high and dry. Because we wouldn't have been able to collect the hospital assessment that pays the state portion of that. But then when it got over to the Senate, they stripped that part out of it. And so while there was no change to the federal FMAP for the childless adult population, it maintains at 90%. Eventually, there's a phase out of what's called the provider tax, which it is assessed. I'm getting into the weeds a bit here, but the state portion of the childless adult coverage, which includes a lot of people with a serious mental illness, is collected with a 6% tax on gross patient revenue at hospitals, and that is collected and then is sent in as the state matching portion for the childless adults. In 2028, it goes down from 6% to 5.5%, and the year after that to 5%. So eventually, within the next 2 years, we're going to have to figure out how to build in about $70 million to cover what will no longer be able to be collected through that hospital assessment. But the good news is the Senate version of that final bill did not change the FMAP rate.
All right, so the second question from Lisa again is about SMI determination. Does having an SMI determination protect SMI patients from Medicaid work requirements? What if you don't have SMI determination? I have heard that it has become more challenging to get an SMI determination.
Yeah, so that's in the category of to be determined. So under Access's waiver that they've already put in, they exclude people with a serious mental illness diagnosis from the work requirements that will be coming at the state level, set aside what the feds just did. Beginning December 31st, 2026, after the next midterms, the states will then be required to have work requirements. But CMS hasn't fleshed out. The bill didn't say exactly who's excluded from the work requirements. So CMS is going to end up having to define the excluded populations. So that's the focus of where that advocacy needs to go at the federal level, is to CMS, to get them to understand that people with a serious mental illness should be exempted from the work requirements and be put into the non-able-bodied category.
Okay, so the next question is from Kim Russell. Do you foresee a special session being called to discuss the One Big Beautiful Bill provisions regarding Medicaid?
I don't think, not this year, because, and we did this, we could do a separate webinar on it, on what ended up the federal bill. But if you look at it in its totality, it's obvious what the theory was of the Republicans who passed this. Is they wanted the pleasure part of this bill, which is the tax relief for wealthy people and also tips. That's immediate. So the reduction in revenue from that bill is something that happens right away. The punishment or the harmful parts of the bill all, except for clean energy, the clean energy tax credits go away right away. But the Medicaid parts and the SNAP parts of the bill are all backloaded. So a lot of the things like the reduction in what you can collect on provider tax, I think that doesn't start till 2027. The work requirements is at the end of 2026. So many of the more painful parts of this law don't take effect for a few years. And in my opinion, some of these things are going to be rolled back by a future Congress and or the deadlines kicked down the road to avoid some of these things like the provider tax limit and stuff. Time will tell. But the answer to your question, I think, is no, in part because the painful parts of HR1 don't start for a couple of years.
Okay, so
And
next,
I would argue that the reduction in revenue is actually a painful part of the bill. I mean, when you have very wealthy people getting even more loopholes, that provides less money for the federal government to provide safety net programs and stuff, and makes us go into even more and more debt and have to service that debt. So I'm not saying tax cuts are awesome things. I believe they're painful too, because of the revenue that we have to forego and the services that we can no longer provide and the debt that we would then incur.
okay, so next question, Will, I think this might be the last question. Oh, no. Okay, so any thoughts on House Bill 2706, the intensive treatment order for court-ordered treatment with oversight to hold SMI clinics accountable? This passed favorably in both chambers, but never got a final vote due to political reasons. And I pulled it up, Will, and this bill would allow the courts to enter an order for intensive mental health treatment services if the court finds that a patient is seriously mentally ill and chronically resistant to treatment.
Yeah, this the only way I can answer this question is really to get more editorial about this. And the bottom line is, look, I'm a believer that people who have a serious mental illness who may not want to get treatment because their illness is affecting their ability to think clearly, and parents know that they need that treatment and go through the process to try to get that treatment. I think that's really important part of public health. There are others who I would characterize as being more idealistic, like the ACLU, who don't believe that court ordered treatment is something that anyone should have to do. And so the ACLU has been a primary entity that has slowed down, if not the reason why secure behavioral health facilities were never built. And in my opinion, they were the reason why this bill never made it through the process, because there's just this, and I like some of the stuff ACLU is doing at the national level. I mean, they're suing the Trump administration for some of the harmful things that they're doing. So they're not like a terrible organization, but they are off the mark, in my opinion, when it comes to their view of court ordered treatment, because they just see it as a civil liberty thing. You're taking somebody's civil liberties by forcing them into treatment. And I look at it more from the parent perspective, who's like, I want my son to live and he needs this psychiatric treatment to get there. And I want a secure place for him to get that, or her to get that treatment. And so it's just a fundamental difference in priorities and values, quite honestly. And sadly, the ACLU is quite influential in this executive branch.
So Will, there's a question in the chat, but I'm not sure which bill she's referring to. It's from Tina. And the question is, are the painful parts of the bill delayed to get past the midterm elections first?
That's an editorial question, and my answer is yes. Yes, that's what I think they did, is that they wanted to make sure that people enjoyed the tax, the rich, wealthy people enjoyed the tips people enjoy the tax relief right away and see that, but the painful parts are not seen until after the midterm election. Yes, I think it was strategic on their part.
Okay, so I don't see any more questions. Well, so if you have any more questions, please enter them in the chat. Otherwise, we will conclude our webinar today. So we'll give a couple more minutes, Will.
Okay, well, thanks for your attention, everybody. And really thanks to all of you who did your part in the advocacy this last session. You know, it really does take a village to get good public health policy. And, you know, we've got, you know, folks out on the call here that have really specific things that they're interested in that they worked really hard on. My general role has been, my general overall philosophy on advocacy is to try to identify those good things that are good for public health that don't already have a well-paid lobbyist who's working on that project. Something that's good policy where you know, my time and effort is something that will provide some value and maybe get something over the line that might not have otherwise passed. Okay. Thanks everybody, and enjoy the rest of the week. It's going to be a hot one. Take care.
Thanks, everyone. Thanks, Will. Bye.